Shalom and welcome again to this week's edition of Seekers of Meaning, the podcast TV arm of Jewish Sacred Aging. I'm your host, Rabbi Richard Address. Thank you very, very much for joining us. Again, if you'd like to make a comment or connect with us, please feel free to email me at rabbiaddress@jewishsacredaging.com. Visit the website, jewishsacredaging.com, the Facebook page, etc., etc. Everybody knows the drill. If not, ask a grandchild because they really do know. We're in the middle of February, and that is usually in the United States a month that's devoted to conversations about heart health. And so we have invited back to our microphone and video contraption here, Dr. Robert Singer, eminent cardiologist here in the greater Philadelphia area. Welcome back, because you've been here before a couple of years ago talking about what was then, and we're going to talk about what is now in heart health and cardiology. So first of all, it's nice to see you again, Dr. Singer. Hope you're well. Hope the family is well.
Everyone's great. Thank you very much for having me.
There seems to be, in the media, and especially of our generation, with the majority of the American Jewish community, according to the Pew studies of several years ago, now all of us over the age of 50, with baby boomers, according to the statistics, now knocking on the door of our 80s, and some of us gently stepping over that boundary. The issue of health and heart health really is extremely important and on the minds of many, many, many families. So that's why we wanted to delve into some of this stuff, bring us up to date on some research, what your experience is. And the first thing I want to talk to you about, because so many of us, me included, are on some sort of statin. So first of all, for maybe the 3 or 4 people left who don't know what that is, what's a statin?
A statin is essentially a cholesterol-lowering medication. And what we're interested in people with cardiovascular disease is keeping their LDL, low-density lipoprotein, as low as possible with a statin. So if there's established cardiac disease, you want to keep your LDL levels very low with a statin. Those numbers are either 70 or less than 55, depending on which numbers you believe. And it's really a treatment for cardiologists and bringing down cholesterol.
The cholesterol thing, we grew up with this. That was the reason people died of heart attacks, et cetera, et cetera. Has any of the research changed in the last 15, 20 years about the level of cholesterol, good, bad cholesterol, other cholesterols? Is there something new on this?
There actually is. Overall, the mantra is to keep the LDL cholesterol as low as possible. So if you have pre-established cardiovascular disease, you've had a heart attack, you've had angina, they've picked up plaque in the arteries, be it your carotids or your heart or elsewhere, you want the LDL as low as possible. But there are some new things out there. In Europe, very often they follow something called apoprotein B, which is a better marker of overall cholesterol levels. We don't usually follow in this country, but I think we're going to switch to it. And then something that's new is called lipoprotein a or Lp(a). It's a marker. At this point in time, it's a once-in-a-lifetime test. So there are some people who have fairly normal cholesterols who have severe cardiovascular disease. They have plaque in their coronary arteries. They may have a blockage of their aortic valve, but their Lp(a) levels, which is genetic and passed on, can be very high. Now, right now, there are no medications for that, but there are some medications in the pipeline. So if you find a patient who has a very high Lp(a), you may not be doing them a service by putting them on a statin, so to speak, but you may want a different agent, which doesn't affect Lp(a) as much, called a PCSK9 inhibitor. Something called Repatha or Praluent is out there also. These are injections you give yourself to lower LDL cholesterol. Those are relatively new. They've been out for some time now, but they're not widely used. They're more costly. And so the insurance companies have you go through the statin route first. But if you have a high Lp(a), then you would rather not be on the statin. You'd rather be on this newer class of medicine, such as Repatha.
With all this vocabulary, which is to us lay people very intimidating. From what I'm hearing you say, a lot of these new APB, Lp(a), they're not widely used by cardiologists. If I go into the cardiologist, my annual checkup, that this stuff is not part of the toolbox yet, or is it?
It is not quite part of the toolbox. It's getting there, but not quite there yet. It's something that I think over time will get more and more because it's being used in Europe more than it is here.
This is a political question. So I don't want anybody to get too offended. With all this stuff that's being used in Europe and not used here, are the government agencies that oversee this in favor of expanding these tests, or are they sort of like marginal? And I guess the other side of that coin is how much do the insurance companies have an impact on what gets in the toolbox?
Well, the insurance companies certainly have a large impact on what gets used. But as far as the testing goes, I think these tests are still relatively new. And although they're using them in Europe, I'm not sure that there have been wide-scale studies in this country saying that they're ready for prime time necessarily. I think most of the lipid specialists will say they are ready for prime time, but it just hasn't spread out yet. So these aren't standard tests that maybe an insurance company would cover.
We've had conversations about the issue of types of imaging and tests that are now available and how often somebody should get. So echocardiogram and cardiac catheterization, these are is a layman's question. Are they normal, or are they to be used, or one of them better than the other? How do you know you need to have these types of imaging exams?
Things like stress tests. People come and ask me, like, should I have my stress test? The answer is no. It's not a screening test. There are false positives you can get, and a regular treadmill stress test is not very sensitive in picking up blockages. It also doesn't tell you whether or not you have coronary artery disease or not. And to get an echocardiogram and the lack of a murmur or lack of shortness of breath or other things, it's just not indicated. You'll pick up some minor things, and probably in a population based, it's not worth it. Something that could be worth it from a radiologic viewpoint, and these are for patients probably between 50 and 75, is something called a coronary calcium score. There are people out there with very high LDL bad cholesterols who never have a heart attack and stroke. And there are also people with normal cholesterol levels, normal LDLs, that have a heart attack and a stroke. And so the question is why, and how can we prevent that? So there's something called a coronary calcium score, again, widely used in the world, but is not covered by insurance, and I don't know why. A coronary calcium score is a very, very quick, low radiation CAT scan of the chest that looks for calcification in the coronary arteries. So as we get older, fatty plaque in the coronary arteries, which is atherosclerosis, becomes calcified. So the more calcium you have, the more coronary artery disease you have. So let's say you have a person there with an LDL, a bad cholesterol of 120, 130, and really not much else in the way of risk factors for coronary artery disease. In the past, we've just put them on a statin to bring that number down. If we have an amount of calcium that you have, let's say it's a calcium score of 0. You don't necessarily need a statin at that point in time. And the same thing goes that, a person with a very low LDL cholesterol that has a high calcium score, well, that person we'd want to put on a statin because that's what we have nowadays to lower LDL cholesterol and hopefully stabilize the plaque.
So does somebody who may be listening to this, who's on their way in the next week or so to their cardiologist for their annual checkup, can they ask for a coronary calcium score exam?
Absolutely. The problem is insurance doesn't pay for it. They don't, for some reason, it's too expensive because everyone would get one. And the insurance companies aren't quite ready for that yet. But the vast majority of cardiologists feel that this is a good test, if I could speak for everybody. This gives you a lot of information. The cost of the test is usually between $100 and $200. I've seen in the past, for a heart health month, that it'll be a $99 special. So it is expensive, but it's not overwhelmingly expensive.
No, because if you and your friend or spouse or buddy go out to dinner, you're going to spend that.
Right. Nowadays, yes.
Has there been changes in the fact that you stay away from processed fast food? I know the government and Kennedy is all about processed foods and stuff, but they're right, aren't they? That's a death sentence, or is it?
If you eat it every day or 3 times a week or 4 times a week, it probably is. The question is, how long are we going to live with all of this, with the processed foods? I mean, does it cut down your life expectancy by a year, 2 years, 2 weeks, 2 hours? It's really, we don't know this, but it is not the best idea. I mean, the best idea is to eat clean as much as possible. Is it forbidden to go to McDonald's? No, it's not. Can you have a steak? Can you occasionally have ice cream sundae? Of course you can, but you just don't want to abuse the privilege.
Many of us have these things, these Apple watches or things that are hooked up to my phone, tells me all kinds of information, whether I want it or not. But the health app, I've had, my primary doctor says, you can really get a good reading on some of this stuff out of your health app. And you can take your EKG and this what is VO2 score?
It's essentially how much oxygen that your body is demanding. And it's very hard to get that from an Apple Watch. I'm not sure that they have it on there, but if you say they do, they do. But it's usually during a stress test where they put a mask on you and they measure how much carbon dioxide you're putting out and how much oxygen you're taking in. It's very important, but it's not a test that's widely used. And it's a tough test to do. So, but the Apple Watches I love. I mean, they give you a lot of information. It could make you crazy sometimes. There are also these rings called, I think they're Auras or Aurora ring. Rings. And they'll tell you, I'll have a patient come to me and say, well, I didn't sleep well last night. It's like, my ring told me I didn't sleep well last night. Like, did you sleep well? Yeah, I felt fine. So it is kind of interesting. Sometimes it could be too much information. But they do give you information on heart rate. They'll soon give you information on blood pressure, and heart rhythm disturbances are important also. And the really breakthrough is going to be when they can give us good information for blood pressure. As you may know, they've reduced the levels of blood pressure for healthy living. And so you really need to focus your blood pressure around 110, 120 is where it should be, which is difficult to attain. And as we get older, our blood pressures tend to go up as we get more arterial stiffness. So the watches and the wearables really will give us a lot of information in the future, but it's at a cost of having that information, and how do you process it without driving yourself crazy?
Yeah, I would imagine that as people are still living longer and older, somewhere there's going to be a class on decoding the information that you get from your watch or your phone or your ring so that you can understand it, because and you mentioned this to me, I think, many years ago. Every body, literally every single human being, is different.
Yes.
And so if person A has this symptom or something, doesn't necessarily mean that you're living in the same environment that you are going to have this same disease or symptom.
Right.
Which leads me to ask you to sort of like riff on the trinity of genetics, diet, and environment, and how they sort of like inform our own heart health.
Before we get to that, let me just go back to the Apple Watch, because a really high amount of problems in seniors comes from strokes, which very often come from the heart and atrial fibrillation. So the Apple Watch is really important to say, how much atrial fibrillation we have, and it can really alert us. People would just have strokes, and then we'd find out that they had atrial fibrillation. And this may be able to tell us before you come in with your stroke that you have this rhythm problem with the heart, which leads to strokes. So I think the Apple Watch is going to be important in the future in defining, and preventing stroke.
There is a thing on the phone or on the watch to warn you about AFib. So anyways, it's still a good segue into the role of genetics. And you alluded to the role of diet and the environment in which we're living in, which I guess also leads to the question, and it's a multi-level question, we're very rabbinic, of stress, and the amount of stress and what that does to the biochemistry of the heart.
Well, it's certainly out there that stress increases cardiovascular risk. And that's how we take in our worlds around us. The world is crazy. We watch the news, it gives us stress. Our families give us stress. Finances give us stress. Some people go through all of this and they don't have any cardiovascular problems. Some people, it really disturbs their health. It can raise your blood pressure. And so we really don't know exactly how this is affecting us, but we do know the stress increases the risk of heart attack, stroke, will increase blood pressure, and the such, which are all risk factors for deteriorating cardiac health. As far as genetic goes, it's always been said if, we ask a family history, what's going on? It's probable that some cardiovascular disease is not environmental, but it's genetic. We don't know what percentage it is. Once again, there are people who eat very clean. They eat wonderfully, but they still will have a heart attack or a stroke, and you scratch your heads why that is, which is why you need to get these markers done earlier, your lipid panels, your LP-Little-A's done earlier in life. But there's also a genetic component, as you had mentioned. Nowadays, we're not using it for coronary disease, but things like weak hearts, cardiomyopathies, which are not uncommonly genetic in nature. So cardiomyopathies could be caused by multiple heart attacks. It could be caused by substance abuse, alcohol abuse. It could also be caused by a genetic marker. And these people, there's not a lot we could do, but we could follow the family tree. And now it's being aware, now with transplantation, a possibility. If everyone in the family has died young and you have a cardiomyopathy, we may be able to watch you closely and get you transplanted before you die suddenly. So again, genetics are up and coming, but we're not all there yet.
The role of diet, and not only what we eat, but as we get older, where we observe our appetites change, perhaps. Is this normal? Are there normal things that as we age affect the heart and our cardiovascular system that we need to be very, very aware of?
In the diet, I think it's a matter of balanced diet, keeping protein in the diet. But as far as what goes along with diet is also exercise.
Yeah.
We look often at frailty. I mean, there could be a 70-year-old person who's quite frail versus a 90-year-old who's quite robust. So the idea of exercise and keeping muscle mass also deals with diet. If we're eating just very little because we just don't want to eat, we're going to lose weight, and I think the frailty will go up. You'll lose muscle mass. So muscle mass is really important as we get older, which is why it's important to do training with light weights as well as cardiovascular training. But as far as diet goes, I think it's the same thing as when you're young and when you're old, what your diet should be, a nice balanced diet.
So the government tells us that I think we're supposed to do 150 minutes a week of exercise, whatever, walking, treadmills, running, tackle football, whatever. Is that still, that's still pretty much the standard?
As much as possible. Again, keeping muscle mass and cardiovascular health is important, and balance is so important as well. So we're not falling down when we get to be in our late 80s or in our 90s. So balance is important. Keeping core muscles strong is really important for an improved lifestyle as we age. And that's what it's all about. So as much activity as possible.
So I've known people, and I'm sure you've treated people who rarely go to the doctor. They say, well, when I get sick, I'll go to the doctor. Since the heart is such a key, it's the quarterback. I don't know why I used that image, but I did. Should we be having a yearly, just like you go to a yearly physical exam, should we also be going to a yearly cardiological exam?
I think you need a yearly physical exam, and I think your primary care physician should tell us whether or not you need to be seen by a cardiologist. I don't think you need a yearly cardiac exam, but you bring up something important about the person who never goes to the doctor versus the person who always goes to the doctor. And it also deals with screening studies. I think we had mentioned in the past MRIs of the body or CAT scans of the body telling us whether or not we have disease or not before we have it. There are some people think this is a wonderful idea. And if you saw 60 Minutes, a gentleman by the name of Dr. Peter Attia, who was a longevity expert, was really into things like this. So if you have a preventative total body imaging, it may tell you you're clean, you're great, and it may give you a lot of oomph that you're going to live, without cancer, or you're going to live well for the next 10 years or so. But if you find something of undetermined significance, it could also ruin you psychologically, knowing that you have something small that needs to be followed. So it all depends on the kind of person you are. Some people think that you should get it done for good health later on, and we could help prevent cancers and cardiovascular disease by looking at these studies. And some people say, I don't want that psychological baggage. And there's no right answer right now.
I got to ask you this one question before we start running out of time, because we just live in very strange times medically and access to medical care. And there does seem to be a growing divide between the people who can access the highest quality care and the people who can't. You as a physician, as a caring physician who I know, how do we begin to well, first of all, is this generality correct? Is there a growing divide between the people who can afford, quote unquote, to the highest quality of healthcare, and a growing disparity between the people who just literally cannot?
There's absolutely a growing divide. There's, as I always put it, rich people's medicines and then medicine for the rest of us. And it comes into the screening. If you have a good financial background, maybe you could spend more time in the gym every week instead of working, and therefore you're going to be healthier down the road. There are tests out there that are not covered by insurance companies that we had discussed, that if you have money, you could go get those tests. If you don't have money, you can't spend it on that. So I think what we need to do to bring up everyone's health is really education. I'll get people in here in the office who say, I'm very active. I exercise all the time. Oh, what do you do? I take care of my 3 or 4-year-old. Now, I'm sure that's my 3 or 4-year-old grandson or grandchild. I'm sure that's a lot of activity. I haven't experienced it yet, but it's not exercise. It's not sweating for 30 minutes a day, 5 days a week, which is what you should strive for. So if you have the means to go to a gym and the time to go to a gym, your health is going to be better than someone who can't afford that time. And as far as the new testing that's out, there's definitely a split between socioeconomic groups. I'm not sure if it's always been there or not, but I definitely see it nowadays.
When I exercise my 150 minutes a week, is there a maximum target level of heart rate that I should look for? Or does it just vary from individual to individual?
There are some people that believe that you should be at 75% of your predicted maximal heart rate, which is 220 minus your age times 70 or 75. And there are some people like myself that say, just go get out there and give it your hardest. Give us a good effort every time. Sweat. Give us a good sweat. And that's what I'm looking for. So I think I wouldn't necessarily go by heart rate, but other people do.
From your perspective, Dr. Singer, with all this that you've talked about, all these tests and what you see in your years, how are you optimistic about the future of cardiac care in this country?
I think cardiovascular care there's exciting changes. We haven't talked about things like aortic valve replacement. Seniors are prone to aortic valve stenosis, a blockage of the aortic valve. And nowadays they do, without opening your chest, they do something to the groin called TAVR, transcatheter aortic valve replacement. You're in and out of the hospital in 24 hours with the new aortic valve. It's amazing. When you had a leaky mitral valve, they used to bring you to the hospital and open up your chest and repair your mitral valve or replace it. Nowadays, they do clips on the mitral valve, again, through the arm or through the groin, and they tighten up the valve. So there are great procedures being done. For atrial fibrillation, are procedures done now that put a block in your left atrial appendage, a little sac off of your left atrium, so you don't need blood thinners. And that's, being elderly and having blood thinners is a pain in the neck because you're more prone to falling and bleeding, and this would take that away. So there are great changes that are being made. Genetics, as you mentioned, AI, we haven't discussed, but is going to change the lives, I think, of 50 and 60-year-olds as they move up.
So everybody has seen TV shows and movies with the guy getting the heart attack. They clutch, they grab. And then we're also reading that women, where evidently the incidence of cardiovascular disease is rising, have different presenting symptoms. Could you just draw us a picture of what those symptoms of men and women are? How different are they? What we should really be looking at or for?
Well, the classic signs of a heart attack are chest, neck, or jaw discomfort, either at rest or with exertion, pressure, tightness associated with shortness of breath or sweating. In women, it happens a little bit differently, where they may not get those classical symptoms. But if you hear what they're saying, it'll be, boy, I just can't, I'm getting exhausted. I'm getting more short of breath. I can't do what I used to do. I have discomfort in my left shoulder. Women, for some reason, don't have the classical chest pressure or chest tightness. Although it still happens in women, it's not quite as common as it is in men. So I think as long as you're listening to your patient and the symptoms, they're there. It's just the classical, I have chest pressure with the Levine or Levine sign, with the pressure in the chest that women don't get as much, but still they do.
So as we close, best piece of advice that you could give somebody? You're sitting around having a cup of coffee, if it's okay to drink coffee. And what's the best piece of advice you want to give to people right now about their cardiovascular health?
Be active. Exercise.
Really?
5 days a week, 30 minutes a session. Work your way up to that. A combination of both cardiovascular exercise, getting on the treadmill, elliptical, and also weights to keep muscle mass. As far as eating goes, eating clean, cut back on the processed foods, get fish into the diet, a balanced diet, eat greens. So it's all the stuff your mother told you. It's really the same stuff. And basically keep pushing at it. Watch your balance, but exercise and clean eating are really the best way for longevity right now.
Dr. Robert Singer, cardiologist, thank you very, very much. As usual, lots of really, really good information, especially that sort of like in the future that's coming soon down the pike. Very, very exciting. Thank you very much. Love to the family, and mazel tov on the stuff that's coming up. Okay, man?
Terrific.
You take care. I'll see you at the ballpark.
Wonderful. Sounds great.
I hope so. To all of you, thank you very much for joining us on today's edition of Seekers of Meaning, the podcast TV arm of Jewish Sacred Aging. We do appreciate your joining us and your being part of what we're trying to do here as we live longer and hopefully live better. If you'd like to make a suggestion about the show or comment, please email me at Rabbi Address at jewishsacredaging.com. And if you'd like to support our work, go to the website. There's a very conveniently located donate button. And if any of you are part of an organization or something that wants to sponsor some of these podcasts, please just email me at rabbiaddress@jewishsacredaging.com. Seekers of Meaning is produced at the Broadcast Center of Lubetkin Media Companies in Cherry Hill, New Jersey. And a special shout out to our guru of electronics, Steve Lubetkin. Until we see each other again on the next Seekers of Meaning, please take care of yourself, stay healthy, live well, listen to what the doctor told us, and most of all, be kind to one another. Shalom.